Good evening, everybody. I'm Dick Milius. I'm chair of the board of Alaska Common Ground. I want to welcome you to tonight's discussion, Medicaid 101, what it is not, and what potential significant cuts could mean for Alaskans. We start today's record by recognizing that myself and many of the participants in today's discussion are in the Anchorage area. As such, we would like to acknowledge that we are on the traditional lands of the Dena'ina Athabascan people. We honor with gratitude the land itself, the Dena'ina people, past, present, and future. Alaska Common Ground's mission is to engage and inform Alaskans to cultivate understanding and cooperation on issues important to our state. Founded by Alaskans passionate about fostering civil dialogue about public policy issues for over 3 decades, we have hosted presentations and discussions like these to build a better understanding of issues important for us all, like tonight's topic on Medicaid. Our distinguished moderator and panelists tonight are longtime leaders in the healthcare field of Alaska. Elizabeth Ripley, President and CEO of Mat-Su Health Foundation, Monique Martin, Vice President of Intergovernmental Affairs at Alaska Native Tribal Health Consortium, Lisa Aquino, Chief Executive Officer of Anchorage Neighborhood Health Center, and Joshua Arvidsson, Chief Operating Officer of Alaska Behavioral Health. Following an introduction by Elizabeth, we'll hear brief presentations from Monique, Lisa, and Joshua about what Alaska's Medicaid program is and its importance to our state. They'll also dispel some myths and explain how a significant reduction to Medicaid might impact individual Alaskans and families, healthcare providers, facilities in our communities, and our economy. Tonight's event is a Zoom webinar. These presentations will take about 40 minutes and will be followed by about 15 minutes of question and answer with our panelists. The event will run until 7 p.m., but we may be able to extend that a few minutes if there are more questions. If you do have a question, please type them into the Q&A feature at the bottom of your screen. We will collect these and Elizabeth will present them to the panelists. This event is being recorded for anyone who wants to watch it later. It will be available on Alaska Common Ground's website at akcommonground.org. It will be emailed directly. It'll also be emailed directly to the folks who signed up for tonight's event, along with fact sheets and other resources. Alaska Common Ground could not conduct the work we do without the support of our members and donors. If you would like to support free events like this for our communities, please consider becoming a member or making a one-time donation at akcommonground.org. Now I'd like to introduce Elizabeth, our moderator for tonight's event. As I said earlier, Elizabeth is longtime president and CEO of Mat-Su Health Foundation. Prior to working for the foundation, Elizabeth held numerous positions in the healthcare industry throughout her career. She has served on the boards of the Foraker Group, Philanthropy Northwest, and Grantmakers in Health, and currently serves on the Recover Alaska board. We're incredibly grateful to Elizabeth for her time this evening, as she's just 2 days away from retiring from her important role at the foundation. Congratulations, Elizabeth, and thank you for your ongoing contributions to the state. And with that, I will turn it over to Elizabeth.
Thank you, Dick. Greetings to our listeners. We're glad that you're joining us from all around Alaska. And we're all here tonight to learn more about the Medicaid program, which is a critical source of healthcare coverage for Alaskans and a major payer for lots of different kinds of healthcare services. The importance of Medicaid to the health and well-being of Alaskans and Alaska's economy cannot be overstated. We'll share with you tonight why it is so important and what's at stake should significant proposed cuts and changes to Medicaid be implemented at the federal level. We've assembled an A-team of incredibly knowledgeable panelists who promise to speak plainly on this incredibly complex topic. And we just really appreciate the time and expertise that each of you are going to share with us tonight. So thank you all. Our hope is that by the end of this, you will walk away with a foundational level of understanding about Medicaid and that you may be curious to learn more. Following the event, Alaska Common Ground will be sharing a variety of resources that you can check out. And if there's enough interest, they may consider future discussions on this topic. So what is Medicaid? Think of the word itself. It's a combination of the words medical and aid. It was created by the federal government under the Social Security Act in 1965. It's administered by the states to pay for health care for individuals who are low income, many of whom are employed. Over the decades, it has been expanded to include people with disabilities, children, pregnant women, single adults, and seniors. It's a major component of Alaska's current healthcare system and infrastructure in both urban and rural communities. Alaska authorized its original Medicaid program back in 1972, and in the year 2000, Alaska launched Denali Kid Care, which is the Medicaid program covering children. A major change occurred in 2015 when Alaska, like many other states, expanded its eligibility to include single adults aged 19 to 64 with household incomes up to 138% of the poverty level. And enrollment grew significantly after that. The economic benefit of this expansion to Alaska was significant. In the first 3 years, nearly $1 billion in federal funding flowed into Alaska's healthcare industry as a result. In addition to expanding coverage, it contributed new jobs in Alaska's healthcare sector. Now let's talk about who receives Medicaid in Alaska. In 2024, as you can see, Medicaid provided critical healthcare access and coverage to roughly 1/3 of Alaskans. That's about 246,000 people. Broadly, who are the Alaskans covered by Medicaid? Pregnant women. Nearly 38% of all births in Alaska are covered by Medicaid. And that has contributed to dramatic declines in infant and child mortality in Alaska and across the country. Children are covered. The Medicaid Denali Kid Care program covers approximately 94,000 children from low-income families or who are disabled. And the vast majority of these children are from working families. It covers primary care for children's mental health and those with individual education plans to help them succeed in school. Most foster care children in Alaska depend on Medicaid for their health care. Medicaid covers seniors and people with disabilities. It specifically supports 80% of all residents in nursing homes or assisted living facilities, who are our parents, our grandparents, and also younger people with disabilities. Medicaid supports people of disabilities of all ages. And Medicaid covers adults. It covers working adults who don't have employer insurance or who don't make enough to afford private insurance. 54% of Alaskan adults with Medicaid coverage are working and not disabled or elderly. Nearly 1 in 10 veterans has Medicaid coverage, and Alaska has the highest population of veterans per capita in the US. Medicaid also covers treatment for people with opioid addiction, supporting the state's focus on eliminating the opioid epidemic. We don't talk about it, but every one of us knows someone who is relying on Medicaid for healthcare coverage. Or we see or know a dentist, doctor, healthcare facility, or community provider who depends on Medicaid reimbursement to get paid for services to serve low-income Alaskans. This federal and state program touches all of us and contributes to our collective health and well-being, our healthcare system, and to our economy. So I want to switch gears now and talk about, well, what is happening with Medicaid? Because it's certainly in the news. And we're hearing about it actually in many different sectors, lots of different circles about potential Medicaid cuts. Our speakers will address this in a bit more detail, but what we do know is that Congress recently passed a budget resolution which lays out a potential $880 billion in cuts to Medicaid over 10 years. That's to the Medicaid program nationwide. Now, the House and Senate are reconvening to negotiate reconciliation bills that may give a lot more detail to what these cuts or changes and how they might then impact Alaska. We will have to see. What we do know at this stage, what we do not know at this stage, but what we will surely be hearing more about in the coming weeks and months are the actual proposed cuts. So it's incumbent on us as Alaskans to understand Medicaid and what the impacts could be on people who receive healthcare through Medicaid, and what those cuts could affect our communities and our economy. So I'd like to introduce you to tonight's panelists, who will share with us their insights on the relationship between the federal, state, and tribal healthcare systems, and the importance of Medicaid on the health and well-being of Alaskans that they serve, and on the economy. And as they speak, please put, again, any questions that you have in the chat, and we will field these at the end of the presentations as time allows. Lisa Aquino, give us a wave, Lisa. There's Lisa. She serves as the CEO of the Anchorage Neighborhood Health Center. And prior to this role, she spent nearly 7 years as CEO of Anchorage's Catholic Social Services. Throughout her career, she also led the state of Alaska's arthritis program, and later the Tobacco Prevention and Control Program, worked as the youth program coordinator for the Desmond Tutu HIV Foundation, and led the statewide Healthy Alaskans 2020 initiative. I'm glad you could be with us tonight, Lisa. Joshua Arvidsson has worked for Alaska Behavioral Health for more than 20 years and currently serves as Chief Operating Officer. He is an expert in trauma-informed care for children and established the Alaska Child Trauma Center at Alaska Behavioral Health. He serves on the steering committee for the Substance Abuse and Mental Health Services Administration's National Child Traumatic Stress Network, and is on the editorial review board for the Journal of Child and Adolescent Trauma. Joshua serves on the board of directors for Focus and has designed and taught courses on clinical practice for the University of Alaska Anchorage. And Monique Martin is going to lead us off tonight. Monique serves as Vice President of Intergovernmental Affairs for the Alaska Native Tribal Health Consortium. She has held several roles at ANTHC, including Chief of Staff. And prior to this role, Monique served as the Director of Government Affairs at Alaska Regional Hospital. She also previously served as the Healthcare Policy Advisor for the Alaska Department of Health and Social Services, where she focused on Medicaid policy work and legislative affairs. Monique was born and raised in Wrangell, Alaska, and is an enrolled tribal citizen of the Central Council of Tlingit and Haida Indian Tribes of Alaska. And so I'm gonna toss it to you, Monique, to lead us off tonight. And thank you again to all three of our panelists.
All right, thanks, Elizabeth. As Elizabeth said, my name is Monique. I work at the Alaska Native Tribal Health Consortium, and hopefully you can all see my screen. Okay, maybe Elizabeth, can you give me a thumbs up if you see it all right? Awesome. So at ANTHC, we've undertaken a study with a national consulting firm, Manat Health, to really understand what's being proposed at the federal level in terms of different Medicaid policy and programmatic changes. So, but what I really wanted to start with a little bit, like who are we talking about in our state that relies on Medicaid for their healthcare coverage? So you've heard some of the facts that Elizabeth already shared. 1 in 3 Alaskans, 13% of children, 7 out of 9 nursing home residents rely on Medicaid coverage to help them pay for their care. And really, Medicaid covers people from all over the state. This is from the slide you're seeing now is a dashboard that is prepared on a monthly basis by the Department of Health to really give you an idea of who's on the Medicaid program. And, you know, I wanted to touch on, there's a lot of different numbers that you'll hear about Medicaid in terms of number of people enrolled. And that's a little bit of the nature of the program, depending on what type of measure that is used, whether it's a point in time, which is really the Medicaid dashboard, really sort of a snapshot of who's enrolled at the time. And this dashboard that you're looking at is of the end of March. And you can see almost 241,000 Alaskans enrolled in the Medicaid program. You can see nearly those 94,000 children, and the sort of the split amongst different eligibility categories. And then other numbers are used, whether they be unduplicated counts. There's a lot of churn in the Medicaid program. If you think about people with seasonal jobs that may be working in the summer months during tourist season, maybe off for a couple of months before some of the winter activities begin. So there's a lot of churn naturally in the Medicaid program. And so there's a lot of different numbers that you may hear. So don't be surprised if you I thought it was 283, or maybe even upwards of close to 300,000 as you start to think people about coming on and off the program, depending on their personal circumstance. Now, who could be eligible for Medicaid? Elizabeth referred to some of the initial different coverage categories of people. Pregnant women, I wanted to highlight back in 2023, Governor Dunleavy introduced legislation to extend coverage for Medicaid benefits for pregnant women. Previously, pregnant woman could be eligible for 60 days postpartum. And now women in Alaska who are pregnant are covered 12 months after they give birth, to really help ensure they're getting the health care they need. But also there's lots of studies that show there's better outcomes for moms and new babies when they're both getting health care for that full year after a birth. You'll start to see children up to 208% of the federal poverty level. And these numbers can be a little bit confusing, so we've included income based on a family of 3. In Alaska, we have a little bit higher federal poverty level than the lower 48. And then Hawaii has a special federal poverty level as well. And you see childless adults, that's really the Medicaid expansion population, the group of individuals who gained coverage back in 2015. I will also kind of give you a caveat to make this a little bit easier. Pregnant women, some eligibility categories have income guidelines that will include things like 225% of the federal poverty level plus a 5% income disregard. And that's just a really technical way to say 230% of the federal poverty level. So just to make it a little bit easier on folks, we've gone ahead and included that 5% income disregard in some of the guidelines below. This is a great slide from the Department of Health that they presented back to the House Finance Committee in February. And I think this really starts to highlight for Alaskans some of the unique nature of our Medicaid program. So there's a chart at the top of the slide that kind of starts to outline the spend, whether that be state dollars in the light blue or federal dollars in the dark blue. So the Medicaid program is a joint program operated by the state with financing assistance from the federal government. And then if you look at the green sort of dotted line, that will show you the number of recipients. That is the number of people who are enrolled in the Medicaid program, but also received services. And that's as opposed to sort of that gold color line. That's the number of enrollees. So there's quite a few number of Alaskans that are enrolled in the Medicaid program, but they do not seek health care for whatever reason that might be. So what I really want to call out on this slide, and we'll spend a little bit of time talking about it later, And I've included some slides that AK Common Ground will share after this event that provides you a little bit more context on some of the information that you see here. So, for example, there are also different federal match associated with different Medicaid eligibility categories. So broadly, adults, or I should say parents, are just over 52%. So federal government pays 52% of the bills and the state pays 48%. The Medicaid expansion population is a 90-10 split. 90% of the bill is picked up by the federal government. 10% is picked up by the state. So if you look at this chart down on 2015, you can see relatively the state spend and the federal spend were pretty even. But when you think about Medicaid expansion going live in September of 2015, about 70,000 Alaskans gained Medicaid coverage because of Medicaid expansion in our state. Then there's that higher federal match where the federal government's paying 90% of the bill. So now we're starting to see an increase where the federal spend is starting to outpace the state spend. Additionally, since I work in tribal health, I think it's important to note, because of the federal trust responsibility for the federal government to provide healthcare to Alaska Natives and American Indian people, and due to the chronic underfunding of the Indian Health Service and the inability to fully fund the Indian Health Service, Congress requires, we are mandated at tribal health facilities across the country to seek third-party reimbursement. So we bill Medicaid, but we also help connect people to healthcare coverage, third-party payers that will help pay their bills. So we have a team dedicated to screening patients to see, do they qualify for Medicaid? Maybe they're eligible for veteran benefits. How do we get enrolled in Medicare? So some of that really starts to play into this, that 100% reimbursement for Alaska Native and American Indian people served through a tribal health facility, also really represented in that dark blue federal funding for the Medicaid program. This is also another great slide from the Department of Health that they presented to the House Finance Committee in February. A little bit of information, confusion about really programs. There is over our state's population that's covered by Medicaid. You start to see on the right-hand side, sort of the gold bar at the top, 10% of our a term I'm not really a fan of, but high utilizers. It's a scientific term or term of art in the Medicaid program, and that really highlights that there are Alaskans that have chronic health that really drive the spend in our state's Medicaid program. Even though we've talked about eligibility categories, whether that be children, disabled children, pregnant women, this looks at across the board in the Medicaid program, where is the spend? And this highlights 10% of the Alaskans on the Medicaid program probably have complex healthcare conditions, maybe 2, 3, multiple chronic conditions that really require significant healthcare need. Expended healthcare need, otherwise known as maybe some high-cost medical bills. So this really, I think, highlights the Medicaid program really does what's it's intended, that those Alaskans with healthcare or complex healthcare needs are getting the level of services that they need through the program. I thought one thing that would be sort of nice to highlight for folks is, regardless if you're on the Medicaid program, which I neglected to mention, you might hear the term Denali Kid Care or Denali Care, and that's really what our Medicaid program is called in the state of Alaska. So if you know someone with a Denali Kid Care or a Denali Care card that they receive, that is our Medicaid program in the state of Alaska. And when Medicaid expansion was implemented back in 2015, one of the things that was really studied following that implementation was what happens to uncompensated care in our state. So if we are covering more people, we said 70,000 more people now have medical coverage through the Medicaid program because of Medicaid expansion. You can see on this line item, hopefully you can see my cursor as well. Back in fiscal year, this is based on the state's fiscal year, there was over $95 million of uncompensated care costs that were provided by healthcare providers across the state. So just because, I think it goes without saying, but I'll say it, that regardless, if you have healthcare insurance or not, you have medical emergencies. You might slip and fall in the ice, break your arm, sprain an ankle, that type of thing. You might have an unfortunate healthcare situation that crops up, and you simply need to go and seek care. So now when you sort of see this dollar amount for uncompensated care start to decrease over the Medicaid expansion implementation, as more and more people are enrolled in the program, more Alaskans have healthcare coverage, and we see that uncompensated care start to decrease in our state. And I think that, right, like if there are costs associated with delivery of care, there's not a magical place those money comes from. Everybody that seeks healthcare is helping to pay a share of those costs, which was a really important part about Medicaid expansion and ensuring that Alaskans have the healthcare coverage that they need. I also wanted to touch on a little bit briefly about some of the uncertainty at the federal level that Elizabeth mentioned. Right now, there's been the budget reconciliation and the resolutions that really serve as the roadmap for where Congress, where the Senate and the House are going to try and find agreement on finding savings in the federal government budget. And some of the proposals that I've highlighted here, really relevant to us here in Alaska, start to highlight some of the things that we could potentially see come forward through Congress. Things like block grants, which really, an easy way to think about it is the federal government establishes maybe a baseline year of spending in the Medicaid program, and then comes up with a measure, maybe medical inflation, some other factor to increase that year over year. And then states operate within that budget however they see fit to best meet the needs of the people in their community. There's also been a lot of talk about reducing the federal medical assistance percentage, the FMAP. The FMAP, I mentioned, Medicaid is a program where the states and the federal government pay part of the bills, right? And one of those areas that Congress is, there's no proposals yet. So I just want to sort of throw that out there. There's no official proposals yet, but these are things that we're starting to hear and see in the news that members of Congress are considering. So I mentioned that the Medicaid expansion population, the federal government pays 90% and the state pays 10%. And one of the proposals that's getting some traction in Congress would reduce the federal match for the Medicaid expansion population from that 90% down to our state, to each state's regular FMAP, federal medical assistance percentage of 52.42%. So that has a pretty significant impact to our state, who then has to decide how would they make up the difference, right? If the federal government is now paying less, that we've built a program, our Medicaid program broadly, with certain services that are eligible to Medicaid recipients, how do we balance that in a time where we see a lot of conversation in our state talking about our state's fiscal future? Another proposal is reducing Medicaid expansion eligibility. So Medicaid expansion is right now at 138% of the federal poverty level, thinking back to that slide on eligibility, and then dropping that down to 100% of the federal poverty level. By nature, that is going to just make less people eligible for Medicaid, right? So those individuals would have to make a choice either to maybe seek healthcare coverage on healthcare.gov through those Affordable Care Act plans, or seek other ways to find healthcare coverage. Per capita caps, we talked about different eligibility categories, right? Pregnant women, parents, seniors, and the Medicaid expansion population. Per capita caps would really look at each of those different eligibility categories and say, okay, each state will get X number of dollars for each person in that eligibility category. So they would get X dollars for every pregnant woman in the Medicaid population, depending on how many months they're enrolled in the Medicaid program. There's also a match that our state gets associated with some of the administrative costs of operating a Medicaid program. Pretty intense. Our state writes about $52 million a week in check write to providers across our state, whether that be to hospitals, but also dentists and eye doctors and folks that are maybe on home and community-based waiver services designed to keep people in the least restrictive care setting there is. So it is a pretty complex program to run. And then also one of the big things we're starting to hear is about reporting work reporting requirements, where people on the Medicaid program, those adults, would have to start reporting to our state that they are either working. Previous proposals have shown that in addition to working, people could report volunteering at schools or their church or other nonprofit organization in their community. So those are some of the proposals that would be coming forward that we expect to see in the coming months. So nothing, like I said, nothing specific yet for us to really dive into yet. But hopefully maybe if there's interest from the group, AK Common Ground would invite us back to talk more about those. Thanks so much, Elizabeth.
Thank you, Monique. Really appreciate it. And as you can see, she has a lot of knowledge in this space, and also in terms of the tribal perspective, which is so key. And now we're going to shift to Lisa, who's really going to provide some insights on the importance of Medicaid from a federally qualified health center perspective and a nonprofit's perspective. And I'll kick it to you, Lisa.
Thank you so much, Elizabeth. Hi, everyone. It's really an honor to be here. In particular, I just want to say it's an honor to be here with this panel. These truly are experts in Medicaid. And so I hope everyone does ask their questions, because these are the folks who are going to answer it, not including me. So, but I'm very happy to be here and represent Anchorage Neighborhood Health Center. So Anchorage Neighborhood Health Center is a community health center. We're a federally qualified health center located here in Anchorage. And we've been here for over 50 years. So we're really, I think of us as just being part of the fabric of Anchorage. And as a community health center, we have a mission. And that mission is to really be a partner in every person's wellness and well-being, and really regardless of their ability to pay. So at Anchorage Neighborhood Health Center, we offer comprehensive primary health care services, which include primary health care on site, and all of this is on site in our building, but dental care, behavioral health care, pharmacy, lab, radiology, care coordination, and so much more. So this model that we have, this is a model that it has been used nationally for many years, and is a way to assure comprehensive primary care, health care for all, because we have some limited grant funds to be able to support folks who are uninsured, so we can see that population and have a sliding fee that can go down and really meet them where they are in terms of healthcare. But you'll see some of our sort of basic stats and overall, but let's talk a little bit about why this kind of healthcare is so important and how it relates to Medicaid. So next slide, please. So I just want to think about, so when you walk in Anchorage Neighborhood Health Center, you have access to comprehensive primary care. So that means you're going to see a healthcare provider who's going to be your person. And then in addition, you're going to have access to behavioral health, who can come in that visit if you're experiencing a crisis. Let's say that I am pregnant with my first child and just terrified. A behavioral health person can come in and talk to you right then. Or let's say you have a more chronic behavioral health issue. We can meet you there where you are. We also have that same service with clinical pharmacy and with so many different kinds of services. And then within our building, we have lab and x-ray, as well as a pharmacy. Now, our model as a community health center is really unique and is special. And I really think of it as a way of really making the most of Medicaid dollars. So when we think about trying to make healthcare systems efficient and work for all of us, I think the model of community health centers is something that we all need to really consider and think about, because we know that healthcare in the United States and Alaska is very expensive and too expensive. And we have to figure out ways to really look at that. And I feel like we've learned some things in our work at Anchorage Neighborhood Health Center that I think can really be impactful, as I know my partners on the phone have as well, or on the Zoom call. So when you look at our overall patient mix, I want to just say that we are a nonprofit. So as a nonprofit, we really have a very slim margin. What we're trying to do with every dollar that we have is to provide comprehensive primary health care to everybody who walks through the door and assure our organization is sustainable for the next 50 years. So within that, we're always trying to operate with the highest quality and the most efficiency. Overall, we bill for about 85% of our total revenue. The remaining 15% are grants. And as I mentioned before, those grants are really particularly to support folks who are uninsured, because this model was developed in the late 60s by the federal government, and those grants are provided in particular for that population. The rest is bill insurance. And as you look at our payer source and where our revenue is coming from, you'll see that 35% is coming from Medicaid. And then when you think about our patients, you'll see that about 35% are Medicaid patients, but actually it's closer to 50%, because within that Medicare piece of the pie, a sizable portion are dual eligible Medicaid and Medicare patients. So about 50% of our patients are Medicaid eligible. And the way that community health center billing works is that we get a rate, one single rate, the prospective payment system rate, and then that amount covers the visit with the primary care provider, as well as lab and x-ray and referral coordination and an array of other services that we try to provide to our patients. And I just wanted to explain that in general so you can get a sense of the intense level of the service we provide. And I want to talk about that because really when we think about what Medicaid is there for, Medicaid is there to ensure that folks who are our neighbors in our community are able to receive the healthcare that they need. And that healthcare is what is going to make them be productive and supported members of our community. So many of the patients that we see at Anchorage Neighborhood Health Center, these are working people who have quite frankly put off healthcare for many, many years, or just not been able to prioritize it because of a challenging financial situations. And so often when they're coming to us, healthcare that if they would have been receiving it regularly for the past decade, health issues that might have been able to be more easily resolved have become challenging health issues. Like I'm imagining someone who has diabetes and they haven't seen a provider regularly, and so they have their diabetes hasn't been in control, and so they're coming to us when they're already having serious symptoms, like their eyesight is getting worse, or they're losing feeling in their feet. And at that point, the challenges of controlling the diabetes are much more difficult, and they're experiencing impacts of diabetes that are going to be impactful in other ways in their life. They might not be able to work and earn as much money as they did. They might not be able to be as productive in their lives. So when we think about why Medicaid matters for your whole lifespan, I just wanted to tell that story and make sure that we were really thinking about that. Next slide. So when we think at Anchorage Neighborhood Health Center, and I'm just going to say in terms of primary care in our state, and for all of the community health centers that I am on a board with the Alaska Primary Care Association with, Medicaid is a critical part of our funding model, and it's incredibly important to so many of the patients that we see. Over 37,000 Medicaid enrollees received care through Alaska Community Health Centers in 2023. So this is a sizable population who is receiving primary health care through our community health centers. And you can see how many of them are children, and you see 6,000 duly enrolled in Medicare and Medicaid. And I just want to call out that most of those are being seen at Anchorage Neighborhood Health Center, because probably many of you recognize and know that our population is aging, as all populations do, but in particular in Alaska, that population that's age 65 and older is growing incredibly fast. And there's fewer and fewer providers in Anchorage who will see Medicare patients. And then in particular, if you're a Medicare patient who doesn't have other insurance, it can be really challenging. Anchorage Neighborhood Health Center will see those patients. Those are people that we want to prioritize and have come through our doors, because we know that if they're receiving strong primary care regularly, then we're going to be able to improve their quality of life as they age. We're going to be able to reduce hospitalizations and emergency room visits. And we're going to make our community healthier in general, and our health system work the way that we hope that it will. So in general, I just want to finish up by emphasizing that if there are the Medicaid cuts and some of the things that Monique was walking through, the reality is that means fewer people are going to get health care. And that's going to have an impact on our neighbors, on the kids that go to school with my kids. That's going to have an impact on everyone, and it's very likely going to increase the cost of healthcare for all of us. Also, for us as community health centers, it will be very disruptive in terms of our sustainability, and something we have to think about. And then I just want to say, as employers, because I know that on the phone with me there are other employers, and as a nonprofit employer, when I worked at Catholic Social Services, many of my employees, they qualified for Medicaid, and they chose that so that their children could be insured. That's a reality for so many people in Alaska. Thanks for your time. I appreciate it.
Thank you, Lisa. Appreciate that. Now we're going to shift to Josh Arvidsson, who's going to provide some insights on the importance of Medicaid from a community behavioral health provider perspective. Take it away, Josh.
Thank you, Elizabeth, and it's great to be with all of you this evening. My name is Joshua Arvidsson. I'm the Chief Operating Officer and Chief Clinical Officer at Alaska Behavioral Health. We're the largest non-governmental, non-tribal behavioral health, mental health provider in the state. And we have 14 locations in Anchorage, Fairbanks, and in the Mat-Su Valley. What I'd like to talk about in kind of the last set of comments here is what the loss of Medicaid or a loss of access of care through Medicaid would mean for a lot of the vulnerable Alaskans that we serve. And I'm really going to focus on the behavioral health system because that's what I know. I've worked in behavioral health for 26 years. I've been a licensed therapist for 20 years. And I'll talk about what this looks like at a kind of personal level for the people that we serve, who are our neighbors and our fellow Alaskans. And so I'm going to share a couple slides here and start off with a statistic that probably a lot of folks who attend these sort of forums know, which is that Alaska has the second highest rate of suicide in the United States. What folks may not be aware of is suicide as healthcare has improved and mortality rates for adolescents and young adults have declined. Suicide is now the leading cause of death in 10 to 24-year-olds, so in our adolescent and young adult population. And untreated mental illness is the principal causal factor. I think when we see statistics like this, it's easy to kind of throw up our hands and say, oh my goodness, what can we do? But it's important not to despair. There are things that we can do, things that are being done, and things that work. One of the things that isn't in the statistic, but I can tell you as a chief clinical officer for a large mental health organization, is that suicide is incredibly rare in people who get treatment. That's what gets sort of buried with these statistics about Alaska having high rates of suicide or negative outcomes. Is the reality is that when people get treatment, suicide becomes a very, very rare event, which to me just highlights the idea that access to care is incredibly important. And that's, what part of what I'd like to focus on in thinking about Medicaid is we've talked about how Medicaid covers so many Alaskans. It provides so many of the essential services Alaskans get, from all the way from dental care to primary care to emergency care to mental health care. But a facet of all those components of service or things that Alaskans access through Medicaid is that Medicaid provides access to care. And we know this from research studies. I know this as a healthcare provider. When Alaskans don't have insurance coverage, when people don't have insurance coverage, they tend to not seek care. Now, the problem with health conditions, and this is very true for mental health conditions, but it's true for most health conditions, is that health conditions tend to be progressive, which means I just won't get help and hope it goes away is not usually a very good strategy. It's not a very good strategy for several reasons. One, because health conditions are progressive. The outcomes, if you wait to seek treatment, get a lot worse. The second is, from a systems perspective, is the cost of care increases quite a bit if you don't get care early. We know this. This is one thing that behavioral health has in common with primary care, is that accessing primary care and getting conditions treated early, accessing outpatient behavioral health care and getting conditions addressed early is relatively inexpensive compared to emergency care or higher levels of care. And one of the things that we're really concerned about is that when Alaskans experience mental health crisis, without insurance coverage to access that care, they will hold off on getting that care and they will end up accessing care through hospitals, emergency rooms, residential psychiatric treatment centers, other higher levels of care that are ultimately quite a bit more expensive and where outcomes are more difficult to achieve. So that's one of the things I just want to really leave you with today, is that when we don't have access to care, it drives up costs. There's a couple points here that I think are really important. Even if you just think about folks who are covered under the Medicaid program, I'd also like you to encourage you to think about people who aren't covered under the Medicaid program, because we're all getting our healthcare services in the same system. And What that means is that if Medicaid coverage is lost for tens and tens of thousands of Alaskans, not only will costs increase for everyone because uncompensated care costs will go up, but we will face access problems. And a concrete example of that is we know when people don't get mental health treatment in outpatient settings, they tend to end up in emergency rooms. That has an impact on everyone. That has an impact on the person who's at the emergency room because they got in a car accident. That has an impact on folks who aren't even having a mental health crisis, but are seeking emergency care for another reason. So the kind of ripple effect of impaired access for Alaskans through Medicaid will have an impact on all of us. I'd also like to address another kind of myth around access when we talk about things like Medicaid. Folks often have an idea that it's this one certain specific population. I'll just tell you, as a clinician who works has worked in practice for over 20 years, a lot of National Guard members have Medicaid. A lot of volunteer firefighters depend on Medicaid. A lot of teachers' aides who work seasonally depend on Medicaid. The Medicaid population is, as was stated earlier, a lot of Alaskans who work seasonally, who maybe work part-time, who are in all different kinds of situations. But I know as a provider who works directly with patients, the Medicaid population is really a cross-section of Alaskans. They're your neighbors. They're fishermen, commercial fishermen in the off season. They're construction workers in between jobs. It's a lot of different folks from a lot of different segments of our society. And so the role that Medicaid plays kind of across the system is really profound. Kind of going back to the concern that I have around access is that access is also a virtuous circle. When people get access to care when they need it, it reduces wait times for care, and it can often eliminate wait lists. We've seen this in our behavioral health system. As we've pushed down and worked on improving access, pushing down wait times for care, what happens is people get treatment earlier. When people get treatment earlier, it's more effective. They're not in treatment as long, and that creates room for the next person. So at our organization, back 5-6 years ago, we had month-long wait lists, in some cases even longer than that. Now our wait times for care is usually, well, for walk-in, we have access every day on a walk-in basis, and for routine appointments, it's typically under a couple weeks. And what that has done is driven down the length of treatment and improved outcomes for the people that we're seeing. So I really get concerned that with significant cuts in Medicaid and access problems, we're going to see costs creep back up, wait lists creep back up, and outcomes go down. So when we're talking about folks who access care through Medicaid, in the behavioral health system, it's 72% of the people that we serve at Alaska Behavioral Health have Medicaid coverage. 72%, almost 3/4 of the folks who walk through our door have Medicaid coverage. And this year we will serve 10,000 Alaskans. We're really concerned that loss of coverage for those folks will inhibit their access to care, and it'll push them into higher costs of care. Speaking of cost, just to kind of talk about what costs look like in our system, the total annual cost of outpatient care for someone that we treat in our behavioral health system is about $5,000 per patient, which is about the cost of 2 nights at API. So, and that's for an entire year of care. So that just kind of highlights the extreme cost of inpatient or hospital-based care for mental health conditions as opposed to outpatient cost. And we're really concerned that the loss of access to care through Medicaid would push people into higher cost systems. So. Finally, I just kind of want to leave you with a little bit of a client perspective on what this can look like and what access to care really means. Like I said, when folks don't have insurance coverage, they tend to hesitate to access care, even at providers that will provide uncompensated care, as all 3 organizations represented here today do all the time. But it causes people to hesitate to seek care when they don't have that insurance coverage. And I'm thinking about many of the children and adolescents that we serve, like a child trauma center and other places, as was noted earlier. Kids in the foster care system depend on Medicaid predominantly for their access to care, their coverage. And I'm thinking of just an example of one of many families we work with a young person who has overwhelming anxiety and is completely distressed, and she starts cutting herself as a result of her overwhelming anxiety. And She reaches out to her parents and she tells her parents what's going on, and they're good parents and they do what any good parent would do, and they reach out for help, and they get her the help that she needs. And that family, three out of 4 times depends on Medicaid to get that care for their child. So she can count on them. Can they count on us? So with that, I'd like to conclude my remarks and turn it back over to Elizabeth. Thank you.
Thank you so much, Josh. I want to, and I think I gave some complicated instructions earlier. I said to paste into the chat, but we asked people to put their questions in the Q&A box that you should see at the bottom of your screen. If you click on that Q&A box, you will see it says open, answered, and dismissed. And if you go to the answered section, you can see that Monique has been steadily answering a number of questions. And so I'm not going to repeat those right now, but I wanted you to see where they were, and you can read through those. And instead, I'm going to go to the open questions and just I think because you mentioned National Guard, Josh, you know, can you explain why active military and vets would need Medicaid? That's a question.
Absolutely. So yeah, so it's easy to think, oh, military, they're all covered through military benefits or TRICARE. That's not actually true in many circumstances. So I can walk through a couple of circumstances where that wouldn't be true. So veterans may be able to access care through the VA, but what about their spouses, their children, their family members, right? They're typically accessing care outside of the VA system, often using Denali Kid Care, Denali Kid Care Medicaid coverage. National Guard members are not TRICARE eligible when they're not on active duty, and our reserve members are also often covered through Medicaid and other insurance plans. So that there's this idea that, oh, if I see someone in uniform or someone who's in military service, they're covered through something else other than Medicaid. That's not necessarily true, and we can see that in the population that we serve in our clinics. You're muted, Elizabeth.
Sorry about that. We have some questions here about access to care. One is related to the Pioneer Home system, and where would folks go if Medicaid were cut, and also if and who are the providers, I guess, that take Medicaid in different communities, and specifically if you were living in Nome, I think that's one of the examples. Where could you go if you were Alaska Native versus someone who is not of Native heritage? Do you have options? Monique, could you field that? Both of those.
Elizabeth, I was busy typing and I missed that first part. Could you?
Sure. The first part was, if Medicaid is defunded, what will happen to the Pioneer Home system? And which is about $11,000 a month. Who would pay for those costs? And the second would be, like, where could I get care depending on my heritage if I were in different parts of the state?
Yeah, if you are a lot of tribal health entities across the state, especially those tribal health organizations where they might be the only healthcare provider in town, serve non-beneficiaries. So if you live in a community off the road system, maybe you live in Nome or in the Bristol Bay area, I highly encourage you to call your tribal health organization to see if they serve non-beneficiaries of the tribal health system. Additionally, the Medicaid program has eligibility for some travel associated with Medicaid beneficiaries. There's actually a requirement in the Medicaid program that beneficiaries are required to seek care as close to home as possible. So that might help impact if you're able to get services in your community or not. It can vary. Some services are not always available at a tribal health organization, but I always encourage people to call. And a lot of tribal health organizations have, we call them benefit enrollment specialists at ANTHC, and they will help community members to go and help sign up for those programs. Maybe you don't have a Division of Public Assistance office in your community, depending on where you are, but I highly encourage, regardless if you're Alaska Native or American Indian or not, to call up your clinic or hospital and see if they have someone that can help you get enrolled in those services. And I think the Pioneer home question is a really good question that I hadn't thought of. I know the monthly rate changed a few years ago, really kind of aligning with Medicare, Medicaid, and some of those for eligibility, payment, etc. So that's one I'm going to have to take back to think about a little bit.
We had some questions around Medicaid being an entitlement, and so I guess I'm wondering, I'm going to pitch it to you, Lisa. In America, healthcare is a privilege, not a right. We haven't enshrined healthcare as a right. And that's why we have this kind of piecemeal system that we're trying to get people covered. So the question, Lisa, is, because the FQHC is seeing people on a sliding fee scale, and you're seeing people that aren't covered. What is their role to be covered, and why is it worth it for the rest of us to make sure our taxes pay to have them covered?
Yeah, it's a good question, and I'm glad that all those questions are there. I mean, let me just go back to and agreeing with Elizabeth's premise that the healthcare system in the United States isn't well built. It's not thoughtfully built. It's sort of it's there's a bunch of different like mini systems within the system that we don't all know how to use it the same way, right? I mean, I bet the people on this phone who are organized, amazing people who could make it onto this call don't understand how to use the healthcare system. They understand what to do. Because there's not just one way. It's really difficult. Start like with that premise. We're all on the same page, but agreed. At this point, it is I'll just say that community health centers were started in the late 60s with support from the federal government because there were large swaths of people in the United States who had no access to health care. And so they were showing up to hospitals with advanced like infectious and chronic diseases and they were also potentially making a lot of other people sick, and they were very that is very costly to hospitals. So it was started as a way to try to bring everybody up to sort of some kind of basic level of access to getting to see a healthcare provider, a doctor, a PA, a nurse practitioner, and getting to have an expert have some sense of your healthcare. But I also think of it as a return on investment. Primary healthcare is a return on investment. And when we think about like, what are the ways is that we want to change this with Medicaid and other programs like that allows all people to have access to primary care, to preventive care. So what that's going to do is it's going to make there be fewer people who are going to need really expensive surgeries and days and days of hospitalization and all of those things that I will tell you cost millions and billions of dollars. And the cost for providing excellent primary care is much, much less. And so this isn't rocket science. I don't need to be an expert in economics to tell you that if we as a state can really think about assuring that we have comprehensive primary care for everyone, we're gonna have a better healthcare system and we're gonna save money. and Medicaid will allow that to happen. Elizabeth, is that close to an answer?
Yeah. Thank you very much. I think, and I want to shift a little bit, but just recapture the fact that I think that you've heard from all these providers that if we invest upstream and keep you healthy and invest in prevention and invest in making sure you have access to care before you get super sick, the emergency department is required by law to take you. And that's where you'll end up if we don't do this investment up here. And the costs, there's no, the cost differential is mind-boggling, which leads me to the question that somebody asked. There's a narrative out there about waste, fraud, and abuse. I would argue that it's waste, fraud, and abuse to let people get that sick and have to go to the emergency department. But there's a narrative, serious narrative out there about waste, fraud, and abuse in Medicaid, and that's one of the reasons that the system needs cut, that it's fraught with these issues. Which of you would like to field that question or give your perspective on waste, fraud, and abuse? Because it's a narrative that we hear consistently. Go ahead, Monique.
Yeah, I think there's a couple things. I think one, we have a pretty robust, so thinking about starting with the patient, right? I think in terms of fraud, waste, and abuse, fraud, there's a pretty robust eligibility process our state has to ensure that people that are eligible for Medicaid are the ones that are really getting the services, one. Two is, I think that when we want to talk about waste, right, I think one of the things we've heard is, people maybe inappropriately using the emergency department. You sort of referenced it, Elizabeth, people accessing the healthcare delivery system at really the most expensive point, right, is the emergency department. And there are a lot of programs. I'm a huge fan of the high utilizer program at Matsu, really designed to really help wrap services around a person. Why are they reporting to the emergency department regularly? Is there some reason their healthcare needs aren't being met? Do they need another medical provider, a different provider? I think like we can all get behind reducing fraud and waste and abuse. I think there's also a lot of focus and scrutiny on providers that bill Medicaid. So the state of Alaska has a Medicaid fraud control unit known as, actually, I think it's the Medical Assistance Fraud Control Unit, referred to as MAFUKU, which is kind of fun to say, so I wanted to say it. But they also do a lot of audits of providers. Providers have to, of all different types, have to do a self-audit and report to the state, were they underpaid or overpaid by the state of Alaska? So there's a pretty robust system already in state Medicaid programs designed to tackle fraud, waste, and abuse. I think the challenge is Medicaid programs may need to kind of come behind and acknowledge that some of these services that we provide to Medicaid beneficiaries might cost money, right? Channeling my inner Elizabeth Ripley talking about, Matsu spent money not reimbursed by any providers in the Medicaid program to really wrap those services around people that were coming to the emergency department a lot. So we need to still, sometimes even for a return on an investment, you have to make an investment. And I think that's a really important part of the Medicaid program.
Thanks for sharing that. Let's shift to kind of the role of providers and the role of the state, because we have a lot of different questions kind of in the chat. And the Pioneer Home sort of started to get there around what's the role of the state? What is your perspective on the state's readiness to address any cuts to Medicaid or any changes to the FMAP that would increase the state's share? Let me just kick it to Josh to start, and then maybe we could just rotate, because All of us who are on this call, assuming you're all Alaskans and assuming you're all over the age of 18, have the ability to vote and talk to your legislator and make your voice heard. And the state is having trouble right now balancing the really very status quo budget that's really surrounded around the dividend and just maintaining. And maybe a small BSA increase, but so this isn't in that budget that's causing them a lot of consternation right now. So Josh, go ahead.
Yeah, well, it's after 7, so I'm just gonna let it rip and say something outrageous. The idea that we could just axe, we built a system in the Medicaid system that relies primarily on federal funds with some state match to those funds. That's the system we have. So the idea that we could just cut that federal support and states are going to pick up the tab would be saying we're not going to fund the military and states are going to pay for it now. That's how ridiculous that proposal would be from a fiscal perspective. The state is not in the position to pick up that nearly $2 billion in federal funding that comes to the state to provide coverage for Alaskans. So I hesitate to give like a serious answer to what in some ways is ultimately, I think, an existential question. What would the state do with a $2 billion hole in its budget? It wouldn't be able to fill it. I mean, I'm not an economist, I'm not a legislator, but I'm a lifelong Alaskan. You can't fill that hole. So that's why this is so significant. I mean, the relationship between the state and the federal government around Medicaid is complex, but Monique showed the numbers of what the federal government covers in terms of Medicaid coverage is a proportion of Alaskans' expenses. What will end up happening is Alaskans will get pushed out of having coverage, and that's not an efficient way to run a health system. And just kind of speaking to your early waste, fraud, and abuse question, I think looking at how you run an efficient and accountable healthcare system is something we all always need to be willing to look at. But the way you solve that problem is not by cutting people's insurance coverage. It's not how you eliminate waste, fraud, and abuse, is by pushing people into emergency rooms and pushing them out of primary care and lower cost forms of coverage.
Maybe I would add, I think that there are a lot, it's pretty complex, right? When I worked at the Department of then Health and Social Services, it takes a lot of work to design benefit packages and who's eligible for what. And a lot of these programs were sort of stood up to help provide lower cost, less restricted services to Alaskans in lieu of a much more expensive mandatory service. So I mentioned home and community-based waiver services, really intense for our state to apply for, outline who will be eligible for what type of services across different different services we would provide to Alaskans with different healthcare needs. So seniors might be different than those with developmental disabilities or co-occurring or chronic conditions. And those services are really provided in lieu of much more expensive mandatory services. So our state would really have to look at who are we serving in a waiver service. So think about if I have a couple of family members that are in a waiver service. They might live in an assisted living home or a group home, maybe for elders, and designed to really provide that person services as close to home as possible in the least restrictive care setting possible. So not everyone needs to be in a nursing home, and we want to make sure that we save those most intense healthcare services for the Alaskans that really need them, and that we provide more wraparound services at a way lower cost for Alaskans who could qualify for that nursing home level of service, but can also be served either maybe even by family members in their own home. So it would be, it's going to be a big process for our state to go through as any of these proposals come up, thinking about work requirements. due to really antiquated eligibility systems, which the governor proposed in the capital budget money to help modernize those systems. Our state has really struggled with timely processing of applications. So our Division of Public Assistance at the state of Alaska does an amazing job with a really, excuse me, a really old computer system. And that makes challenges like processing SNAP, food stamp benefits, supplemental nutrition assistance program. We've seen that newspaper coverage where our state is sort of out of timely processing with applications. So our state is a little bit more challenged in terms of having to work in a system that is really old in terms of computers, right? And I don't mean 5 years, I mean like 30, 40 years old. These systems that are really sort of really challenging for folks to work in. And that means it takes longer for our state. So if our state has to implement work requirements, they're adding on to an already stressed system. And a group of amazing folks, eligibility technicians that work at the Division of Public Assistance, working in these old systems, trying to make it work, right? And we simply don't want to add additional administrative burden, additional government resources to a system that just is already stressed at the time.
Thanks for that, Monique.
I was just gonna add, the thing to think about when we think about that shortfall is remember, like, so much, like the healthcare system in the United States was so much built on and depended on employers paying for insurance, right? And having more Medicaid is covering folks, a lot of whom are employed, but whose employers don't offer health insurance through their work. And like that has been a change and a cut. And so part of now where we are in our healthcare system is that employers are covering less and less. And I know as an employer that it's because it's harder and healthcare is so expensive. So I'm not trying to point any fingers, but I'm just trying to say it, as we look at those Medicaid cuts and potentially losing Medicaid, more costs are also going to fall on employers in Alaska. I think that's inevitable by having less access to Medicaid.
There was a question about the role of the Alaska Mental Health Trust Authority and the behavioral health system and Medicaid that I think, Josh, you answered in the chat. But maybe, Josh, let's just conclude here with what do providers think about this? How important is Medicaid to the providers, specifically the behavioral health providers? And when you're answering that, maybe, and we'll start with you, Josh, maybe also talk about the role the trust played, and I think Monique can add to this as well, in actually helping us expand Medicaid. I know that Matsu Health Foundation, we supported Medicaid expansion specifically to increase access to behavioral health care, and we have the data to show that's exactly what happened. So Josh, could you speak more to that? Because what we're seeing, and I would just say this to folks out there, in every age category, the prevalence of mental health and substance use is increasing in our population. It's increasing in our emergency department. And it's really a crisis for Alaska and America. And so, and Medicaid plays a huge role in getting access to care. Josh, you want to talk about that?
Yeah, so the Alaska Mental Health Trust Authority provides critical support in addressing gaps in care, in launching initiatives to improve the system of care, in helping launch new programs where there's gaps in care, either in particular types of services or geographic areas of the state. It is a bit of a myth that the Alaska Mental Health Trust Authority can like underwrite the operational costs of mental health care. It's not an insurance program. It it's not able to offset Medicaid or other payers for ongoing operational expenses. That's like a really simplified, not trustees approach perspective on what the role of the Mental Health Trust Authority from a behavioral health provider perspective. Kind of one thing I'd like to say from our perspective, like I said, 72% of the people that we serve depend on Medicaid for access to coverage. And that role that Medicaid plays doesn't just provide access for the people who are covered by it, but it also supports the operation of the entire system for everyone. And what I mean by that is that, 2 years ago, we launched a partial hospitalization program, a day treatment program for Alaskans with really high levels of need as an alternative to going to the hospital. That program is super effective. It's accessed by Alaskans. We have a children's program, adult program, folks from all different walks of life. We have folks in uniform, folks who access that program who are in military service. Without the Medicaid population, that program probably doesn't exist. Without Medicaid, the Alaska Child Trauma Center, which also serves children without Medicaid, it's hard to imagine that program existing. So, people sometimes when they get in the math, they don't think about what it really means. Like if you say, well, we're gonna, 50% of a hospital's operating costs or 30% is covered through Medicaid. So there'll be a 30% reduction in that hospital's operations. Maybe with a 30% cut, that hospital isn't there anymore. That's what people need to really keep in mind is like you can get lost in the numbers, but like, and Lisa shared this, and I really appreciate her sharing this. Our organizations as nonprofits, we're rolling all revenue back into providing services. There's not huge operating margins. So when you look at taking a large population sort of losing coverage and increasing uncompensated care, it can mean programs close. I mean, I'm not trying to scare people, but that's the role that Medicaid, whether you have Medicaid or not, the care that you access is in part supported by everyone who accesses that care in their insurance. And a big portion of those people are covered by Medicaid in Alaska, whether you and your family depend on it or not.
Thanks, Josh. Lisa or Monique, any final thoughts before I kick it back to Dick to close us out?
I think Josh did an amazing job sort of summarizing that, right? Like we have a fragile healthcare delivery system in a state like ours, right? Small state, giant geography, and how do we really serve the healthcare needs of Alaskans? And Medicaid expansion, if you start thinking about that, has brought a lot of behavioral health services to Alaskans, saves our prison system, saves the state of Alaska money in terms of the state of Alaska can bill when a person who's incarcerated needs to go into a hospital for cancer treatment, for appendix removal, whatever that might look like. As soon as that person who's incarcerated needs to be admitted to a hospital, we can start charging that to the Medicaid program. In tribal health, as I mentioned, Congress requires tribal health entities across the country to bill and seek third-party reimbursement. Medicaid makes close to 50% of our bottom line at the Alaska Native Medical Center. So if you start to think about what does that mean for our healthcare delivery system broadly, when 1/3 of the population no longer has a payer, I think there's some mandatory populations where we might see things like when our state, I mentioned, expanded eligibility for pregnant women, we really went from the minimum of 60 days to 12 months. So now we're gonna, if our state had to, I'm not saying they are, but if they had to make that tough choice and say, we can't afford it anymore and ratchet that back down, that means poorer health outcomes for pregnant women and children, which mean more health costs later in life, right? So these programs are really designed to sort of we want to make the best use of our healthcare dollars. And that's so much of what the importance of having more Alaskans covered, whether that's through employer sponsored, Medicare, what you name it, Medicaid, having everyone having a payer for their services really helps bolster the system and support that system entirely.
Thank you, Monique. Any final comments, Lisa?
No, I think these geniuses already covered it. I mean, this is really complicated. As you can see, we could talk for.
Thanks so much, Lisa. Thank you to all of our panelists. And Dick, I'll let you close this out.
Okay, that was an excellent overview of what Medicare is and what impacts Alaskans can expect if there are significant federal budget cuts to Medicare. My one-word summary of my concern is that it's alarming. I encourage everyone to follow what Congress is up to and encourage people to write to our delegation if you have concerns. If you go to their websites, they have a link for sending emails or telephone calls. A big thank you to Elizabeth for moderating this evening's discussion, and to our panelists, Monique, Lisa, and Joshua. We know your time is precious, and we're grateful for you for sharing your knowledge and insights with us, and it's grateful that you stuck around for a half hour before what we committed you to answer questions. A huge thank you to Alaska Common Ground's ad hoc working group who put this event together under the able leadership of Danielle Williams. The work group included Jess Brunlich, Cliff Grove, Stephanie Nichols, Hannah Laird, and our very knowledgeable volunteer, Steve Williams. An additional thank you to Jess Brunlich for setting up and running the Zoom show this evening. Even though you didn't see her on the screen, she's kind of behind the scenes running the whole show. And missing from this Zoom event is the sound of the applause that everyone watching tonight would like to give you. A special thanks to all of you who took the time this evening to join us and learn about this important issue to our state. If you are not already a member of Alaska Common Ground, we invite you to learn more about our organization and consider becoming a member or making a one-time donation at alaskacommonground.org. Your support fuels our work to advance a more informed and engaged Alaskan democracy. Thank you again for joining us. Stay healthy and engaged, and have a good evening, everybody. Thank you again.